Okay, so the next presentation is going to be given by Danny Tsai. Danny's a clinical pharmacist who works at Alice Springs Hospital, and he's the intensive care unit pharmacist there, and he noticed in his practice a lot of uncertainty within his clinical group about how to be treating Indigenous Australians that are critically ill and requiring antibiotics. And so he's decided in his PhD that this is the problem that he wants to solve. So,
thanks, Jason, for the introduction. So my name is Danny, and today I'll please bear with me for 10-15 minutes for my presentation. And I feel I'm really humbled to be given this opportunity to share our findings here, especially after these world leaders in the research field of infectious diseases. So Alice Springs, I lived in Alice Springs for just over 7 years, and it's right in the center there. And Alice Springs Hospital provides medical service to a catchment area of about 1.6 million square kilometers, roughly represented by the red pentagon. And sepsis is a huge issue in the Indigenous population. And in Alice Springs Hospital, we have about 200 beds and 10 ICU beds, and about 85 to 90% of our patients are Indigenous. So a study that was conducted in Alice Springs Hospital a few years ago has found that about 60% of all hospital deaths are related to infection, or comparing to 25% in the non-Indigenous population. And of that 60%, about 56% of them were bacterial sepsis. Another study that was performed in Royal Darwin Hospital, they found that the Indigenous population has 4 times higher sepsis hospital admission rates comparing to the non-Indigenous counterparts, and 3 times higher severe sepsis admission to ICU. So it is a huge issue. And currently there's not a lot of research that's looking into this area. Overall, they're younger, but they are sicker. So they end up having a very similar mortality rate when comparing with the non-Indigenous population in the ICU. So in terms of physiology, they have about a young and healthy Indigenous person would have about 30% less nephrons. Right, so they have much less to start off with. And it's suspected that this is one of the main reasons why the renal impairment rate is so high in this population compared to the non-Indigenous. But we don't know whether what effect it has in acute setting. In terms of their body build, they are generally slightly smaller, but with much higher central fat and much slimmer limbs. And a study looked at the allele frequencies of 2 CYP enzyme 2C19 and 2D6, and they found that the Australian Indigenous population share very, very similar allele frequencies to Asian population, Southeast Asian population, but they didn't actually look at the other CYP enzymes. And this may be significant, which I'll talk about in the next slide. And also, there are high rates of some rare adverse drug reactions in the Indigenous population, especially in the Central Australia. So there we're seeing much more stress syndrome and toxic epidermal necrolysis from phenytoin. And that's also due to some pharmacogenomic issues. So if you have a look at this table, which look at the pharmacokinetic differences between different ethnic groups, and you find that so all these patients, they are healthy volunteers, and when they're given the same dose of the same drug, and you compare the AUC or the drug exposure, you find that there are differences that may be up to 2 or 3 folds. And in general, Asian people achieve higher concentrations in their blood, and this is especially true for antibiotics that are predominantly or partially hepatically cleared. So if you put all that together, and then plus everything we've heard so far today, all the pharmacokinetic differences, changes that you will experience in critical illness, you might start to wonder, well, would a dosing regimen that is designed for a specific population, can we extrapolate that to another seemingly different ethnic population? So this is why we came up with this particular set of projects. So two aims. Number one is to optimize dosing of commonly used antibiotics in critically ill Indigenous patients with severe sepsis. And we looked at these 4 different drugs. And number two is to look at the prevalence of ARC and AKI in critically ill Indigenous patients, because these, most of these drugs we're looking at, they are predominantly renally cleared. So methods, so basically Indigenous patients, adults, severe sepsis, that are prescribed with the study drug. And then if they have end-stage renal failure, or if they're on dialysis, or if they're pregnant, they're excluded. It's an observational study, so the regimen is determined by the treating doctors. And demographics, clinical information, they were collected as well. And a series of blood samples were obtained at these specific time points, according to the dosing interval of that particular antibiotic. And then after centrifugation, the plasma samples were then frozen at minus 70 degrees Celsius. And then they were batched and then sent to BTCCRC here. And once we have the concentration time data, then basically we did the population modeling, and all these processes, I won't go over them again because Claire did a really good explanation of them earlier today. The second study, which is to look, we actually looked at the creatinine clearance of Indigenous patients in our ICU. Basically, we included everyone that walked into our ICU that actually has an urinary catheter institute, and basically we collected 8 hours of urine every single day for the entire duration of their ICU stay, and then we worked out the measured creatinine clearance. And then upon data analysis, there were a few things that we looked at, which are the prevalence of ARC and AKI, and we looked at the differences between Indigenous and non-Indigenous patients, and we also looked at the risk factors for ARC. So in terms of results, in terms of the piperacillin study, basically we found that a 2-compartment model adequately described the data. We found that weight and creatinine clearance, or measured creatinine clearance, they were the only covariates that significantly affected pharmacokinetics. And in general, we found that there is a large inter-individual variability in terms of these pharmacokinetics. But in general, the clearance in the Indigenous population is slightly lower when we compare them with the non-Indigenous critically ill data. However, from our dosing simulation, we actually found that we came up with this particular dosing table, and we found that this dosing table looks very, very similar to what we find in a PI, and which is quite different to some of the other studies that are performed in non-Indigenous critically ill patients, and that might be due to the fact that they are achieving slightly lower clearance, and that might be due to the non-renal clearance pathway. Anyway, so when we come to dose these patients, just like Professor Udi has talked about today, ARC is a major killer, and ARC can actually requires you to actually dose your patient quite, increase the doses quite a lot. And especially if you dose your patient according to the MIC of the bug that you have cultured, For example, if you look at someone who has a creatinine clearance of 170, you actually need a 24 grams of piperacillin continuous infusion to actually achieve that PK/PD target. So to look at meropenem, meropenem is extensively renally cleared, and we have not found any significant differences between between indigenous and non-indigenous patients, but we actually found that our indigenous group has much lower creatinine clearance. Hence, we have actually achieved a much lower clearance. So that can be accounted for. When you dose your patients, you just make sure that you do a very accurate measurement of the patient's creatinine clearance, preferably by urine collection. And for vancomycin, we've just completed the vancomycin study, and the interesting thing is that we actually are able to identify the loading doses, and we find that the loading doses is actually quite significantly dependent on the creatinine clearance that is achieved, that the patient actually has. Because in the past, quite often we actually thought that regardless of their renal clearance, we still give them the same loading dose, and then we'll worry about the trough level later on. But we found that it's actually, if we actually give, let's say, someone with a renal clearance of about 20, and we give them a 40 milligram per kilo dose, then they can actually reach toxicity and stay there for a very long time. And also another thing is that we also identify the time to next dose. Quite at the moment, it's not really well defined in the literature. Literature now is generally recommending loading doses, but they don't really give us a really good indication of when we should start giving the regimen. So we've also identified that. And then the maintenance regimen. So lastly, ceftriaxone. Basically, we found that a non-compartment model adequately described the data. So we found that there's not a clear relationship between the clearance of ceftriaxone with the measured creatinine clearance. Interesting thing about this is that a regimen of 1 gram twice daily, which is a very commonly used regimen in our hospital, and we found that it actually achieved a free drug concentration of at least 4 milligram per liter. And if you look at the MIC of typical bacteria, which can be treated by ceftriaxone, all of them are either 1 milligram per liter or less. So if we're able to achieve a trough level, a free drug trough level, at least 4 milligram per liter, then we are really, really optimized. We have really optimized the therapy. So we thought that, this is an observational study, and we're pretty happy with this particular regimen in this population. So results from the CROC study, the creatinine clearance study, which we were able to carry out with help from Professor Andrew Woody. We actually looked at the ARC, like we talked about earlier, and we found that the ARC days achieved in the indigenous population is actually significantly higher than the non-indigenous group, and that is more than likely due to the fact that we have a much younger population coming into ICU in the indigenous population. And but if you look at the acute kidney injury rates, then they are similar, which is quite interesting because if you think about it, if they're younger, then the likelihood of achieving AKI should be less. Anyway, so we're seeing similar rates of AKI with non-indigenous population, but we're seeing a high rate of ARC comparing to the non-indigenous. So therefore, we have less patients that's sitting within the window. So that's why it's really important for us to make sure that we measure the creatinine clearance properly in our patient population. And so we also looked at some of the risk factors for ARC, and we found that age and major surgery. These two are big factors which actually increases your chance of getting ARC. But if you have diabetes, which most of the Indigenous population have diabetes in Alice Springs, and that actually reduces the chance of getting ARC, and that might be due to the effect of the albuminuria. So basically, in conclusion, we found that there is a large inter-individual variability in the antibiotic pharmacokinetics in our patient group. And creatinine clearance has the strongest association with meropenem, vancomycin, and piperacillin pharmacokinetics. Accurate assessment of creatinine clearance is really, really important. And generally we found the clearance in our patient are slightly lower, but it just means that we actually achieve slightly higher levels when compared with a non-Indigenous population. We found, once again, a higher rate of ARC in our patient group, and similar rates of AKI when compared with the non-Indigenous group. Thank you very much.